Classification of old diseases has changed. For example, adenovirus infection was a very trivial few years back. The child used to get a fever, rash, conjunctivitis, and used to settle in a period of 5, 6 days. But nowadays we see adenovirus infection causing a fever for 3 to 4 weeks, such a high-grade fever. And many of the patients get complicated with a severe pneumonia and ARDS. Also, new diseases have appeared, like multisystem inflammatory syndrome. COVID, though it has disappeared these days, but it has kept its footprints for next few years, and we see that in day-to-day practice. Lot of diseases that were present before, like nephrotic syndrome, Guillain-Barré syndrome, the incidence has increased to 4 to 5 folds as compared to the pre-COVID era. And this is all because of immune dysregulation caused by the COVID antibodies. And a lot of diseases that were existing before, they have taken a fulminant course. We see quite often plain enteric fever, which we were treating with oral antibiotics or sometimes with some simple injectable antibiotics few years ago. But nowadays, we need to, these patients develop endotoxic shock, severe myocardial dysfunction requiring inotrope and ICU care. So over a period of time, lot of diseases spectrum has changed. And over and above that, because of the small family norm, the parental anxiety has become very crucial in day-to-day practice. Whenever any child gets admitted in the hospital, on the day one itself, the father asks, so what is my child diagnosis, how many days the child will require hospitalization, what will be the prognosis, so on. So many of the times clinical diagnosis become difficult, and that is why there is need of multidisciplinary approach. So these points I will highlight two various cases. So my first case, he's a 1.5-year-old child. He presented with a history of high-grade fever for a couple of days and severe diarrhea and vomiting for 1 day. This child was brought in a very bad shape to Sai Sparsh Hospital. On admission, the child was toxic with such a high-grade fever of 102, marked tachycardia, poor peripheral perfusion, the capillary refilling was prolonged. Though the blood pressure was reasonably acceptable for the age, the child had a mild tachypnea, but saturation was low, the chest was clear. Except tachycardia, the CVS was normal. Per abdomen, there was liver palpable 2 centimeters below costal margin, but soft in consistency. So this is a scenario each and every pediatrician face day in, day out. So looking at the clinical picture, we thought of it's an acute gastroenteritis with a severe dehydration because the child had a significant amount of shock. So we started the child with a normal saline bolus after securing the good IV access, and we literally pushed the fluids because the child was in a shock. IV paracetamol was given and oxygen started, but surprisingly, within 10 to 15 minutes after arrival, the child started desaturating. Heart rate went up to 180, peripheral perfusion was still poor, respiratory rate again increased to 80 per minute. So we were wondering why it is happening. It's like a plain gastroenteritis should respond to the fluids. So we have a ultrasound and echocardiography machine in our pediatric ICU. So we decided to get an immediate functional echocardiography done of this child. And this is the echocardiography. You can see heart is hardly pumping. Ejection fraction is hardly 20-25%. There is a thin rim of pericardial effusion as well. So thus, because of that, the child was not tolerating the fluids. So we further investigated. His hemogram was showing leukocytosis, and the CRP was 188, sky high. So we were thinking in terms of severe septicemia, but the blood culture was negative. D-dimer was 11,000 when the normal value is accepted is up to 500. NT-proBNP is a cardiac enzyme, and it elevated NT-proBNP indicative of myocardial inflammation. And it means the heart is under stress. So it's a sky high, more than 35,000 is many of the times is associated with a poor prognosis. So then we investigated, the COVID IgG antibody was positive, IgM was negative. So there is a history of, it seems that there is a history of past COVID infection. So, provisional diagnosis was there is some myocardial issue. It could be viral myocarditis, but the inflammatory markers are not that high normally in viral myocarditis. So it was less likely. Cardiomyopathy was possible. Cardiomyopathy was possible, but this child has presented very acutely, and the child had thrived very well till the onset of this illness. That's why it was also less likely. So our final diagnosis was it was a post-COVID multisystem inflammatory syndrome. And it's a very new entity. In last few years after the COVID, it is antibody-mediated cytokine storm causing severe myocardial dysfunction. And it requires very specific treatment in the form of IV immunoglobulin, high-dose methylprednisolone. And as the D-dimer was quite high, this child received low molecular weight heparin dobutamine infusion, and after 48 hours of therapy, the ejection fraction was done, that was 45%. So there was significant improvement in the cardiac function, and we could discharge this patient successfully. So, about the tachycardia, this child has presented with a tachycardia. But in children, there are a lot of confounding factors for the tachycardia. Fever is the most important. The child's heart rate is very sensitive to the temperature. 1 degree elevation in the temperature causes elevation of the heart rate by 12 to 14 in children. Many of the times, child is excessively crying. Again, that causes tachycardia. Nutritional anemia is present in many of the children, and that causes tachycardia. So, depending on only heart rate, we cannot pick up the shock in early stage. And whenever patient goes into the late shock, when there is already hypotension develops, then we clinically can diagnose, but that is already late. If shock detected in early stage and intervened very immediately, the child's prognosis will be 90%. Whereas in late shock, if we intervene, the prognosis will be only 40%. That's why we need to take the help of investigation like point of care echocardiography or ultrasound for the early diagnosis of shock. So ultrasound has become like a stethoscope these days, and it's an integral part of any like intensive hospital. So how it helps? Like it helps in assessment of the intravascular fluid volume. Previously, we used to keep the hand on the liver while we were giving the boluses, but nowadays you check the IVC is collapsed, it means the patient is hypovolemic. You give a bolus, check the IVC, if IVC is expanding well, it means your patient is responsive to the fluids. So it's very useful for management of shock. Lung ultrasound has literally replaced the X-rays. Even the small pneumonatic patches, which are not diagnosed on the X-ray, can be detected by the ultrasound. Other conditions like pulmonary edema, pneumothorax, effusion, everything can be diagnosed by the ultrasound, and we can do it multiple times. Neurosonography in the tertiary level NICU is very important because merely 700 gram, 800 gram, 24, 25 weeker baby is not important, but neurological integrity, how baby is neurologically, that is more important rather than saving the child. So neurosonography has become an integral part of the neonatal ICU. UAG guided various procedures can be done very easily in the intensive care, like tapping, ascitic tapping, pleural tapping, liver abscess aspiration, ventricular tap, central line insertion, hydrostatic reduction of the intussusception is possible in-house. And again, echocardiography is very helpful for the management of shock, response to the inotrope, and for the assessment of the myocardial function. Also, pulmonary hypertension. So, pediatric pulmonary vasculature is very sensitive to hypoxia in contrast to the adults. That's why even any slight amount of hypoxia can cause pulmonary hypertension. And again, unless you treat pulmonary hypertension, your hypoxia will not improve. And that has been diagnosed only by the point of care echocardiography. So my next case, she's a 6-year-old girl presented with a fever with chills, vomiting, pain in abdomen. On examination, she was toxic, sick looking with a right hypochondriac tenderness. So immediately we got an ultrasound done. UAG was showing liver abscess. The child was started on IV antibiotics, but again it was a huge abscess. The child was sick, so we decided to drain that abscess. So our interventional radiologist team decided to do the USG guided liver abscess aspiration. As you can see, by USG guidance in that abscess cavity, and once the tip of the pigtail is in the abscess, we aspirated, and we kept that pigtail for continuous drainage. So roughly around 300 ml of pus was drained. So surgery was avoided by merely this in-house ultrasonography and non-invasive intervention. The child was given vancomycin wash to the pigtail. Fever disappeared within 2 days, pigtail removed after 7 days, and on follow-up after 2 weeks, ultrasound was showing complete resolution of the abscess cavity. So this is a very funny case. It's a 22 days old, very small baby, 2.5 kg, was admitted with a mild fever, cough cold for 5 days. This baby was admitted in our NICU only for like 36 hours for routine preterm care. He was a 35-weeker, 2.3 kg. So we discharged immediately on second day. And after that, for 15-20 days, the child was reasonably okay at home. No family member was suffering from any respiratory illness. On examination, on admission, the child was sick and febrile. Some amount of tachycardia was there, but peripheral perfusion was good, but the tachypnea was there. So respiratory rate of 88 per minute with intercostal, subcostal retraction, saturation was low, started immediately on oxygen. Respiratory system was suggestive of bilateral crepitations, but there was no murmur or no signs of CCF. So looking at the whole thing, it was looking like a septicemia with septic shock. So we investigated. The hemoglobin was 15, the WBC count was 31,000. Then platelets were okay, the CRP was high. This was the X-ray on arrival. You can see the right-sided diffuse haziness, so looking like a pneumonia. So our differential diagnosis was it could be bacterial pneumonia or it could be septicemia. Or in the current monsoon season, we get a lot of viral illnesses. So could be some viral pneumonia, maybe RSV, adeno, influenza, etc. Or it could be some congenital heart disease like TAPVC, which may sometimes present like this. Or it could be aspiration pneumonia secondary to gastroesophageal reflux disease. This was started on good antibiotic cover, but along with the antivirals. But on day 5, the child didn't show any improvement. The lung were worsening, distress was increasing, O2 requirement was rising. So antibiotic were stepped up to meropenem, levofloxacin, and empirically IV amphotericin was added. And the child was taken on HFNC. And you can see the serial counts. The WBC was persistently high. Neutrophilia was there. And CRP were also persistently high. This child was not responding to our current management. And this was the X-ray done, which has shown progressive lung disease. So the lung pathology has increased. So we got a HRCT done. As you can see, there is a bilateral symmetrical nodular opacities, like suggestive of a severe consolidation. So we were wondering why the child is not responding. So we decided to do a bronchoscopy and bronchoalveolar lavage. And you can see for such a small baby, we underwent this one bronchoscopy. You can see the granulation tissue at the carina, and even the granulation tissue was present even in the proximal main bronchi. So we have given a bronchoalveolar wash and sample was taken. So the bacteriological evaluation suggestive of it was positive for acid-base bacilli. So it was looking like a endobronchial tuberculosis. We got it confirmed by the CBNet. CBNet came positive. The child was started on AKT with 4 drugs, AKT and with steroids. And subsequently the HFNC was weaned off and the child was discharged on day 10, day 11 of AKT, and on follow-up, the child is gaining weight. Respiratory-wise, the child is absolutely fine. So from this case, without bronchoscopy, we could not have diagnosed tuberculosis in such a small baby with a persistent neutrophilic leukocytosis with a high CRP. We were never thought of tuberculosis. Because of scopy, we could do it. So my next case is a 6-year-old child with a repeated episodes of diarrhea and vomiting.
Sir, time is over, please.
Couple of minutes, sir. So this child had multiple diarrhea episodes, and they were lasting for last 2 years. And this child was not gaining weight. So the ultrasound was done that was showing mesenteric adenopathy. The child was put on AKT, but there was no response to the AKT. So the child was brought to us. On examination, nothing significant except anemia. So we thought it is not infection, it is something else. So we got a TTG IgA level for celiac disease that came positive. So GI was planned, and you can see that there is a marked villus atrophy along with the hyperplasia of the crypts, suggestive of celiac disease. This is a normal mucosa, and this is a normal ideodenal mucosa, and in celiac disease, this is the picture. And it confirmed our diagnosis. The child was started on gluten-free diet, and within no time, the child was absolutely asymptomatic. This is one more child who had a severe PR bleeding, came to us with a hemoglobin of 3, and there was a bleeding polyp. And because of colonoscopy, we removed that bleeding polyp, and the child became absolutely all right. My last case, this is a 15-month-old child who presented with a few respiratory symptoms followed by multiple episodes of convulsion and altered sensorium. So this child was referred to us because of rapid neurological deterioration. Required multiple anticonvulsant, midazolam drip, so continuous EEG monitoring was started, ventilated, adrenaline drip was started for shock. CSF was normal, except high proteins. So this child was started as a routine protocol, ceftriaxone and acyclovir. And this is the MRI. We got this MRI in the middle of the night at 2 o'clock. We wake up the radiologist and ask him that we wanted MRI urgently. And to our surprise, the MRI was showing bilateral thalamic and basal ganglia lesions and white matter changes. And this classical picture is suggestive of acute necrotizing encephalitis. So acute necrotizing encephalitis is like a cytokine storm of the brain. And it can kill the patient, or it can destroy the brain very rapidly. Within a few hours, it can become a brain death. We have seen the patient who has had a breakfast in the morning and become brain dead by afternoon. It's a very common complication of dengue these days. And it requires very aggressive treatment. We immediately started on methylprednisolone, IV immunoglobulin, tocilizumab. All 3 drugs were given within first 6 hours. The child was ventilated and discharged on day 10. The child had some neuromorbidity on discharge, but at least we could save the child because of continuous monitoring, rapid investigation, and timely intervention. So this is the child after 6 months after discharge, neurologically normal. So take-home message is the pediatric practice nowadays is a multifaceted. It requires multiple faces, multiple super specialists to help us, multiple gadgets like ultrasound, echocardiography, multiple scopes, ventilators, syringe pump. Then only we can give justice to our patients. Thank you.